of the lecture. We're going to discuss the prevention strategies. Hand hygiene. I cannot emphasize enough how important it is to wash your hands. Hand washing, or even using the alcohol-based sanitizer before and after manipulation of the catheter. We know as nurses we should always wash our hands before doing anything, but it's extremely important before any contact with the catheter. You saw the detrimental effects that a CAUTI can have, so something as simple as washing your hands can help. As discussed, determining necessity is huge. If we don't need it, then we shouldn't put it in. We always want to ask every day, can this Foley be removed? You don't want to wait until the end of the shift. Even though it's very convenient, I get it, it's definitely not a necessity. Using the correct techniques. You always want to use the aseptic technique every single time with no exceptions. The size of the Foley can also make a difference. The smaller, the better. You always want to shoot for a 16 or an 18 gauge. There are some exceptions. Patients who have chronic Foleys, they can go all the way up to a 24, but you always want to try for the 16. You want to keep the sterile drainage system closed, and you always want to maintain an unobstructed urine flow. You want to keep the catheter and the collecting tube free from kinking. Again, maintaining that you never want to break the seal in the drainage system. You want to keep the collecting bag below the level of the bladder at all times. You don't want to rest the bag on the floor. You just always want to keep it below. If you're up ambulating a patient, I've seen people get, use pretty neat ways. They would put it in they have a little pocket in the bottom of their pants. You could even put it in there. Put it on the walker. You just always want to keep it below where the insertion site is. You want to ensure that only trained personnel are permitted to insert the Foley. At my facility where I'm currently working, CAUTIs are so important that they're changing the whole policy. A lot of our patient care technicians will insert it currently. And that's going to change. As of July, we are requiring not only one RN, but 2 RNs in the room to insert a Foley. And that's just to, again, try to maintain the septic procedure, using the aseptic technique. I know we already went over last semester the Foley insertion. This is going to be a quick review, just emphasizing the things that you want to keep in mind when you're putting a Foley in, keeping CAUTI in the back of your mind also.
I'm going to demonstrate Foley catheter insertion. We have checked our orders, we have the right patient, we provided privacy, washed our hands, and we told our patient what we're going to do. And the next thing you do is open your catheter insertion kit. And the outer cover is actually going to be used as our trash can, and we're just going to set it on the bed, and we'll put our betadine cotton balls that we dispose of, and everything will go into this trash can. Okay, we're going to open the tray away from us. This is going to be our sterile field. Okay, the first thing you do before you put on your sterile gloves is pick up your drape by the corners, shiny side down, and this is going to go underneath the buttocks on the female and then underneath the penis on the male. So this will be our sterile field on the bed. And then grabbing the center of the gloves, you can take those off our sterile field. Now we don't want to touch anything else. I'm going to move to the side and put on my sterile gloves. And even if they don't go on correctly, you can readjust them when you get them both on. because usually they do. Okay, now you're sterile, so you want to be careful what you touch. You can grab the center of your wrapper and toss it behind you without lowering your hands below your waist. Grab your kit, move it to the center of your table. And I'm going to rotate my box where the box with the Foley catheter and the bag is closest to the patient. There's another drape in your kit. It's the fenestrated pad. It's got the hole, the triangle in it. This can be used, but for simplicity, we are going to have all students use just the rectangle pad. Okay, your kit actually comes with the betadine, the cotton balls, the forceps, your lubricant, sterile specimen container if you need a specimen, and your 10 cc's of normal saline that we'll inflate the catheter bulb with. So what we want to do first, you want to open your betadine and put that on your cotton balls. Okay. Just lay that down there. Mix up your cotton balls and your betadine. And then open your lubricant, which you're going to lubricate your catheter tip with. You can put it in any of the container or the openings in your kit is fine. And this we'll just toss into our trash can. So we did our betadine, our lubricant, and now we want to test our catheter bulb to make sure it inflates. And I find it easier to leave it covered so you're less likely to contaminate it. We'll go ahead and attach that to your port and inflate your bulb to make sure it inflates and it's not leaking. And once it's inflated, it's not leaking, go ahead and deflate it, but leave your syringe attached to your Y port. Almost deflated. Okay, let the syringe attached. Now go ahead and you want to uncover your catheter, but be careful not to let it flop and hit something that's not sterile. Now you're going to place the catheter tip in your lubricant. Lubricate about 2 inches of the catheter tip, and you can go ahead and leave that in the lubricant, and that kind of holds it in place. Now at this point, what you're going to do is now your non-dominant hand is going to become contaminated because you're going to use your middle finger and your thumb to hold open the labia. Then you're going to take your cotton balls. The first one's going to go down the center, one swipe, and toss it away. Then you can either go on the left side and dispose of that one, and then the right side and dispose of that one, and then just throw your forceps in your trash container. Now I'm going to take my bag and my lubricated tip, and my kit's still sterile, so I can take it over here and put it on my sterile field on the bed, being careful not to contaminate my gloves. Then you're going to have your patient take a deep breath. And you're going to insert your catheter. Be careful that you wouldn't want to touch your sterile hand to your patient as you're inserting it. Once you see urine in your tube, you can go ahead and insert it about another 2 inches. Then at this point, your non-dominant hand is going to come down and hold your catheter. This hand is now, it doesn't have to be sterile, and you can inflate your bulb. And if they complain of pain, you'd want to reinsert it a little bit more to make sure it's not in the urethra. It inflated fine. Disconnect your syringe. Then you're going to pull your catheter down to the base of the bladder. Take your catheter bag, make sure it is clamped closed. Hang it on a part of the bed that's not moving, just the bed frame, not the bed rail. Tape it to the leg of the patient, and you're going to document any drainage, the color of urine, and how the patient tolerated it, and the size of the catheter. We have an order. We're going to DC the catheter on our patient. What we need is washcloths, towels, things that they can clean up with.
So I'm going to stop the video there. I will upload all of the videos that are in this lecture into the content section so that you can review them again if you wish. For this part of it, though, we don't really need to see the removal of it. I want to go on to some more prevention strategies. The pericare is also extremely important. You want to do routine catheter care at least twice a day. We usually recommend once with the bath. So if your morning shift gives the patient a bath, do pericare. And then on the shift where the bath doesn't occur, you want to clean the peri area and the tubing. And of course, after each fecal incontinence episode, you always want to clean that fully. You want to use soap and water. The blue bath wipes, they're acceptable to use. I know at my hospital we have the blue and the gray. The gray you are not to use, but the blue are okay to clean the Foley. You should always use a front to back cleaning technique for female patients, and cleansing cloths should not be rinsed and reused in the male patients. Make sure to clean around the tip of the penis. You always want to assess the skin in the perineal area every shift and obtain orders for treatment if there's any yeast infections that you note. Stabilization. The StatLock is a really good device. That keeps that Foley in place, so we can always make sure it's not going to be moving around, causing possible bacteria to go in. But you need to apply it correctly. The catheter, you should always adhere to the front of the thigh, allowing for 1 inch of slack in the catheter tubing. And you always want to make sure the arrow is facing the patient. And then, of course, the plastic holder is snapped shut. Of course, we always want to look at alternative methods to the Foley. The Foley should always be the last resort for a patient. The condom catheters are a great device for male patients who are incontinent, who you can actually get a correct I&O for them if it stays on. The incontinence pads, they're really good, and I know they make better ones now that can hold up to 1 liter of fluid without letting it touch the skin of the patients. Bladder scanners are great. I know at my facility, they now implemented a protocol where we can actually, without a physician's order, use bladders. We always use bladder scanners, but if the patient has greater than 350 cc's, we can do a one-time straight cath. And then, of course, if they're maintaining 6 hours later, they still can't urinate, then we'll let the physician know. But the bladder scanners can give you an accurate amount, even though some patients may go 8 hours, but they only have 200 in there. So you don't want to always just go right to the Foley. And then the intermittent catheterization, as I was saying, for those once or twice deals, or the neurogenic bladder in post-op patients, they don't always need a long-term Foley catheter placed. You can just do a couple of straight caths. So for a quick review, you always want to know, is the Foley catheter appropriate? We discussed multiple ways of whether it's just a convenience or whether we need it. Should the Foley catheter be removed today? That should always be a question on the forefront of your mind when you come in and get reported and your patient has a Foley. You always want to investigate, why is it there? How long has it been there? Can we try to get it out today? Who should insert the Foley? Look at your hospital's policy. Should it be a nurse? Should it be 2 nurses? Is a tech able to do it, and are they all qualified? Have they had the right training? Aseptic or clean procedure? Always aseptic, 100%. And then when you're cleaning, when you do the pericare, obviously that's a clean procedure. Closed or open drainage system? Always closed. You never want to open that drainage system. Maintain an unobstructed urine flow, always. Standard precautions, that's pretty self-explanatory. I know we've drilled that, into our heads as nurses. You always want to wash your hands. And then, of course, always look at the alternative methods, which we just discussed. And that's it for our lecture for tonight. There's going to be several activities and readings, so make sure to look at the content section on this module. Thanks, class.